Welcome everyone to today's webinar. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. Our presenters for today's webinar are Chuck Winnie, Principal with Infor Healthcare, Mark Weber, Senior Vice President for Infor Healthcare Solutions, and Dan Miller, Senior Product Director at Infor. At this time, I am pleased to turn the floor over to Mark to begin today's presentation.
Great, thank you. And thanks everybody for joining us today. We're actually really excited to be able to talk with you today about what we see as a major challenge and opportunity within healthcare today, provider healthcare in particular, in terms of how we can start to address the challenge of cost and what that and ways in which we can approach that going forward. So just to kind of level set, right, the challenges today with healthcare include a number of things, right? Health policy uncertainty, right? We know that there's a lot of complexity in the regulatory environment right now, a lot of uncertainty with what's happening with the Affordable Care Act or can replace the Affordable Care Act. There's also a lot of new payment models around that, right? So there's been a lot of back and forth in terms of some of the bundled payments and what's going on there. But you know, the overall drive there is to try to get better control on those costs. Of course, we also see this in doing that, right? We see this shift to value-based care, trying to go from, you know, volume-based reimbursement models to more value-based reimbursement models, trying to look more and more in terms of population health and trying to look at the cost of the entire continuum of care rather than just a particular episode. And, you know, that's resulting in a lot of eroding margins, right? More and more organizations are having to live within Medicare margins. More and more organizations are having to think harder and harder about operational efficiencies. You know, Medicare reimbursements are not tending to increase, and neither are commercial reimbursements. And what the data shows is that overall within provider healthcare, prices are going up, or your revenues are going up about 6% overall as an industry, but operating expenses going up 7.2%. So as long as, you know, your expenses are growing faster than your revenues, you're going to have eroding margins, and it's not a sustainable model going forward. Of course, the other big industry dynamic is around consumerism, right? Care affordability is a huge topic right now, as more of the cost of care is being shifted from either, you know, the government payer or third-party commercial payers to patients. They're becoming, you know, much more selective about the type of care they receive, when they receive care, and even if they receive care, right, which can, of course, have downstream impacts in terms of their overall quality of care, which can also then negatively impact costs going forward. They're also, you know, much more sensitive on the cost transparency as well, right? And they're going more and more to alternative care delivery models. You know, you're seeing a lot of entrants, you know, with CVS and Amazon and others that are really trying to come up with ways to give consumers other mechanisms to receive care outside of the traditional healthcare provider models. The other big dynamic here, of course, is staffing shortages, right? So we've got nursing shortages, primary care shortages, and from a cost perspective, what that means, of course, is that as the supply is more and more constrained, the costs tend to go up, right? And we're seeing that. We're seeing, you know, nurse wages are rising faster than inflation. There's significant challenges and bonuses that are having to be paid in order to get nurses and primary care physicians in locations where they're needed. So all of this, of course, is driving, an incredible pressure in terms of within healthcare. And even as recent as yesterday, as I was scanning my news feed, right, you can see this kind of thing happening. This is a recent report from Fitch Ratings. You can see here, right, I'm talking about how hospitals and health systems face further deterioration of operating profits as new competitors emerge, like CVS Health, Amazon, and other non-traditional entrants. So these guys are just getting started, right? So we're going to continue to see a lot of challenge on margins and on revenues within the traditional provider healthcare community. So in order to maintain those margins, in order to stay viable, of course, you're going to need to have a better understanding of costs and better understanding of alignment of cost to the services that you provide. If you look at the way we've done that traditionally, right, way back in 2000 and before, right, it's largely been around looking at patient charges, looking at patient claim data. And, the good news is you can, trace that down to the patient level. You can get patient level information. However, what it doesn't tell you is a lot about, a lot of the non-revenue producing activities. It doesn't tell you a lot about the indirect charges that are being incurred. And it gives you, therefore, limited models and ways in which you can try to directly allocate costs and fully allocate costs there. Since then, right, we've seen a huge rollout of electronic health record systems, and that certainly gives you a lot more detailed information, and it's an electronic format, which is great because it makes it a lot more accessible, and you can, start to have a more thorough understanding of, the clinical and operational drivers. But it also has its own challenges in terms of allocations of unutilized resources. And you can start to get into challenges of looking at how the models operate in real life. So you can get yourself in a position more just to be, sort of simplistic about it. If you're looking at, let's say 4 nurses covering a floor with 10 patients, if you look at the cost per nurse per patient, that's going to be a lot lower than if you were looking at a floor that had 2 nurses with 10 patients, right? So you can start to overburden the system by allocating, patients to the area where the costs look lower than they actually are, and not have the real understanding in terms of how that capacity is actually being utilized. Today, what we're starting to see is as organizations are starting to develop more fulsome ERPs in their back office systems, that it's starting to give now a platform that you can use to fully understand your operational cost. So if you have the ability to look at your capacity rate drivers, if you have the ability to look at your supply chain costs, your financials, and your human capital management costs all in the same place, and then align those back to your EHR with the actual drivers of those costs, that is now getting us to a point where we can do a much better job in terms of understanding not only the complete cost picture, but also to be able to understand how those costs actually align to the procedures and the DRGs as they're defined within the EHR. And from that, right, you can start to look at, more sophisticated analyses around capacity balancing, where do I have excess capacity, where do I not, looking at, where costs might be higher at one facility versus another, look at where, there might be other drivers to the cost that you can now start to allocate at the actual DRG level, right? So from where we sit, right, we're really starting to see now this shift as folks are starting to now get the full understanding on the business operations side. Couple that with your alignment to the electronic health record. We feel that provider healthcare is now in the best position that it has ever been in terms of being able to understand both, to understand those cost drivers. So so what do you need to do to make that work, right? Well, you need to have, the full view of your operating expenses. You need to have the full view of your labor, right? Your salaries, wages, and benefits. You need to have a full view of your supplies. You need to have an understanding of your assets, depreciations, leases, et cetera. You want your pharmaceutical costs, of course, a big driver of costs overall in there. And then you need to understand what your administrative expenses are and the allocations that you want to use for those. That's on one side. On the other side, right, you need to understand your patient level activities, right? What kinds of activities are being performed for the patient, whether it's, acute, ambulatory, the procedures, what are all the components that are going into that patient level, those patient level activities, so that you can then associate them to the expense on the other side. If you actually start to marry these together, then of course you can start to look at, your percent of allocations, what your actual utilizations are against those activities, and you can start to better define exactly how those costs play out. To do that, of course, you want to understand what those utilization drivers are and have a model for those, and then you're going to have to think about what's the weighting of those drivers in terms of that model. So playing that out in a little more detail, right? So if you've got a system or systems that you can tie together that bring in your general ledger, that bring in your supply chain, that bring in your workforce management data, that bring in your human capital management data, and that you can also have a view of your asset management. You can then pull in your department activity logs and your, capacities and your capacity constraints that are being realized within your organization. You pull all of that together, and what that starts to give you then is a deep view in terms of the cost of care data that you have. So putting that in, some form of data warehouse, now you can start to apply costing analytics on top of that, right? And from there, that starts to give you the kinds of views that you would want to see, right? So taking a look at cost of care variation. When I worked at an academic medical center, we used to have to do a lot of this kind of thing by hand. And we would see where you could take a report of cost per surgeon, and you could see where, a certain surgeon might have higher costs than another surgeon. And then we could drill into, well, here's why that person's costs were higher, right? Here was, supplies that this person used perhaps that others didn't, or used more of than another person didn't. And that way, as, operational folks and financial folks, you can engender a conversation with those service line level leaders to say, hey, I may not have an MD, but you might want to know, right? Here's how these costs lay down, and here's the breakdown. As you get more sophisticated with this, right, you can start to look at what is driving that cost of care variation. So it's simple to say that, Dr. A uses a gizmo that no other doctor uses, and, maybe the service line level leader wants to have a talk with that doctor about whether he really needs that gizmo. What will become more sophisticated as you get into more refined clinical data to be able to look at what are those clinical drivers and what is a driver and what is not in terms of cost. So, probably find that, some clinical variation is directly related to cost and some clinical variation is not. And then being able to determine to what degree that clinical variation matters is going to be really important in terms of defining at a refined level that overall cost of care variation. Of course, you also want to look at, the outcome experience, what are patient costs by day, how much is, how much is from a population health perspective and from a cost risk perspective, which are the patients that are costing me the most? What's the risk, my cost risk going forward with this patient? What can I do as an organization to help better support the clinical quality while better managing that patient's costs. Looking at unutilized capacity. We all know there's a lot of unutilized capacity within the healthcare system, be they, machines, MRIs, et cetera, or, building capacity, or even people capacity in terms of labor. So being able to get at this data can start to give one a better understanding in terms of where that capacity is utilized, where it's unutilized, and give the opportunity to start to try to balance that capacity. And then, of course, in other areas in terms of engagement and staff turnover, we all see lots of heuristics about the cost of staff turnover. You can say nurse. I've seen everything from, nurse turnover is 1x salary to 2x salary. Well, knowing more precisely, based upon this kind of data, what that actual experience is in terms of what's that actually costing you at a given unit in terms of that turnover, can help you be much more refined in terms of those costs and where you want to make investments in terms of staff or other means of whether it's hiring the staff or overtime or bringing an agency. Having a better understanding of that overall cost of labor against those procedures can be very instrumental in then helping you understand how you want to deal with those kinds of costs. And then if you think about where one could go forward with all of this, right? If you start thinking about, artificial intelligence or robotic process automation, right? There's a lot of opportunities once the data is in place to look not just kind of currently and retrospectively in terms of costs, but to use that data to start to be a little bit more prospective and predictive in terms of what your cost outlooks are going to be. This is the kind of thing that other industries do a lot, and something that has not yet hit healthcare in a big way because we haven't had this view of the data to actually be able to pull that kind of thing together. So, looking at that data to think about, capacity balancing, not just within a unit, but across the system. So if we've got, 10 regional hospitals and trying to determine where perhaps the best 3 that we want to have as our birthing centers, that kind of capacity balancing and information would be very, very helpful, and that you could pull out of data like this. Process automation, right? So there's a lot of processes that occur within healthcare that are quite manual and routine and rote. Taking a look at those, understanding where those processes can be streamlined, where you have enough information to be able to automate some of those processes so that you can take the human element out of it and take that, rote human element out of it, get humans focused on doing what humans are best doing, which is making decisions, and get the machines to deal with process automation and managing those processes. And then, just in terms of, staffing, looking at skill mix, are there, if you were to take a breakdown of the procedures and the tasks that are performed within a unit, are you being efficient in terms of the level of skill that is performing that task, right? So we know that, a big dissatisfier with nurses is the amount of scut work that they typically wind up doing that is, far below their licensure level. If we can use this data to be more discerning and discriminating in terms of letting nurses and other care professionals operate at the top of their licensure and fully leverage the skills and the experience they have to do those high value activities, and then be more discreet about how we separate out, the lower value activities and have those aligned to, labor that's less expensive, you can potentially provide, the same tasks and the same overall care, but at a much lower cost point, because you're aligning the cost of the sophistication of the task with the cost of the labor better, right? And then we've also seen where using, sort of more scientific processes around talent hiring and talent acquisition, where you're actually using science and this kind of data to bring in folks, can actually have an improvement in terms of overall diversity of your workforce, which just works for everybody, right? So what we've modeled out in our organization is, because we're heavily involved in the manufacturing sector as well, we've taken a close look at the process manufacturing model. So process manufacturing are, like making shirts, or where you're driven by, say, size, color, and fit, right? And creating a lot of, and those are your drivers in terms of how you're actually manufacturing. And their models are actually, rather similar to the kinds of, process in our services within healthcare. So we've taken a close look at their models in terms of how they do cost modeling. And let's be clear, right, that the folks in retail live and die, and folks in manufacturing in general live and die by how tight they're able to control their costs. And so we've taken that model, and this is basically how they break it down, right? They add up all their supply costs, add up all their labor costs, equipment, facility, and all their processing costs, right? And then they add to that their unutilized capacity, right? Add in your general overhead expense, any exclusions, and then having all of that then allows them to have that fully reconciled to their GL account level expenses, right? Another challenge I had in my prior life was we could do some of this, but being able to rationalize it back up to the GL was incredibly hard. So in process manufacturing, again, they'll take a look at all those supply costs. So if I were to translate that to healthcare, right, it's looking at your direct and indirect medical supplies costs, your implants, pharmaceuticals, et cetera, right? All supplies. That's not comprehensive, of course, but taking a look at all your supply costs. Then looking at all your labor costs, right? Your clinical costs, your non-clinical costs, any purchase services that you have that go into labor. Looking at, the equipment, maintenance, leases, rents, all the equipment that we have in hospital systems, including depreciation. Then adding in all of our facilities costs, right? Then adding in our process costs, right? That a lot of processing with coding, billing, care coordination, et cetera. Taking a look at that unutilized capacity and adding that all up. So that's how we're starting to look at this and how we're starting to break it down from a process manufacturing perspective. And it works, as you can see, right? It works pretty well in terms of adding this all together and being able to reconcile it to the GL. Just sort of a sample of how that might look, right? So you can imagine if you could put all this kind of thing on a dashboard, right, and aligning it to your clinical data, getting, say, a CFO dashboard that's looking at your cost by service line. You could see, here's an example of just, various service lines, overall costs, then being able to select a service line, break it down, say, by physician, as I know that we used to do by hand, and then being able to further, categorize those costs by direct or indirect, and then be able to further drive into those. Or even from a service line perspective, if you look at the bottom middle, right, being able to decompose that service line into each of their sub-services, take a look at the costs, et cetera. But, clearly in healthcare, it's not just about cost. We have to think about quality, right? So showing that kind of data in context with your clinical data, right? Showing it in context with, your average length of stay or your readmission rates or your adverse events rates. Because the last thing you want to do, right, is lower costs and you have a negative impact on quality. But if you can show that either A, you can lower costs and not impact quality, or maybe, you have areas where it's worth it in terms of, investing more on the cost side to do something like lower average length of stay so that the overall cost is lower, that can be, very, very compelling in terms of trying to think through how you want to actually pull all of this together. And so this is just sort of a simple example within, say, the four walls of the hospital. You think about, where this could go next in terms of looking at the overall continuum of care. So since we're looking at, kind of orthopedics here, we know that, if you say had a joint replacement, if you're going home to rehab versus going to a rehab center, going home is actually much less costly, right? So if you were to look at this, say, from a continuum of care perspective and start to look at those costs, post-surgical, right, would be sort of the next thing to pull into all of this. And then you could start to look at, okay, how often are we, sending people to rehab versus home? You could have a physician breakdown of that, or you could start to look at what are the characteristics that are in common, what are the drivers that seem to occur in terms of people who rehab at home versus those who go to a rehab center, and then how do I better control for that? Because if I can start to better control for those kinds of things that result in, large swings in terms of cost overall, I can get, back to population health, right? I can start to look at a much, much more efficient, delivery of care, at the same quality or higher, right? So this is just, again, just sort of an example in terms of how this might lay out. You might, consider, especially depending upon the service line, different clinical measures on the left. We used to look at, who's and who's data in the orthopedic area in terms of, post-surgical quality. But you're right, but just, you can imagine that we'd start to refine this, based upon service line and based upon the relevant quality indicators for that service line. So this is just kind of a way to start to look at all of that. So how do you get there? Right? So what we're finding is it takes a journey, right? Today, the cost processes can be quite opaque, and because they only look at direct costs, that's the only thing people trust. The notion of adding in, these kinds of indirect costs can be met with some resistance, right? So the big trick is to start to get folks to work with you in terms of being transparent about those indirect costs and the allocation process against those, as well as what are the drivers to those? Which drivers are you selecting? How are you weighting those? And getting agreement then with the service line level leaders and their financial folks in terms of why those drivers and weights have been chosen and how they actually work. And then once you can start to get one or two clinical areas bought in, right, and you can actually start to show it working, right, and then work with them in terms of perhaps adjusting those weights and drivers and giving them that feeling of control over those. Everybody's going to start to get a lot more motivated in terms of eliminating that cost variation and starting to advocate and promulgate it going forward. So it's all about getting this process to be more transparent and getting more of that buy-in. And the kind of mathematical model here, can't be talking about cost accounting without showing a little bit of math. Got to have at least one equation. So here's basically how the activity cost calculation works, right? So you're looking at a percent of a resource. You're looking at the utilization of that resource times, the intensity weighting that we talked about before, divided by the overall capacity, right? So how much capacity you actually have. So that then defines your cost activity, right? And then it's the sum of these cost activities that you can pull together and align against, particular, clinical unit or DRG or whatever. And that then becomes the sum of the cost that you're using from a cost accounting perspective. So does that all hopefully that all makes sense. I'm sure folks have a lot of questions. I've got a couple of our deep subject matter experts here, and Chuck and Zan Miller. So we are happy to open the floor. I want to allow plenty of time for discussion around all of this. So questions? Chuck, I think you were
Yep.
taking a look
Yeah,
at
we have a couple
questions that are
really
coming in.
good ones that we have a couple really good ones that I'm happy to bring up. One consistent theme that we've gotten in a couple questions is effectively how does this relate at a actual patient level? How does this concept it directly relate to out-of-pocket costs for patients and the burden over them? Mark, I think that'd be an excellent question for you to field.
Yeah. So, you know, what we see is that as more of the costs of care are being transferred to the patient, right? A lot of ways that employers and payers are lowering costs is creating, you know, high deductible payment plans and such, right? You really do start to see that people are making choices around whether or not they receive care. And, you know, care affordability then becomes a huge component in terms of whether or not people are receiving care. And, you know, care that you can't pay for is care that you don't see, right? And it affects the overall mission of providing care. So having a better understanding then of how you can help, how you can understand the costs, and then being able to translate that for your patients so that you can help them in terms of, you know, what they have to pay for and their affordability of care is where you can go with all of this kind of thing, right? Because if you don't know what those costs are, or if you can't, you know, explain, you know, what cost a patient can expect in terms of a procedure, then there's no way that you can really help them in terms of, you know, how they can best manage their care within and make it affordable for them. There's actually, I'm sure if you go look, there's actually it's a few years old. It's pretty amusing on YouTube about a young man trying to just ask around and find out what the cost of delivering a baby is for his wife, and nobody could really tell him. It's that kind of thing, right? If you were able to actually inform this person in terms of what those costs are, and inform that person in terms of how they can better manage their cost of care, because you know what those costs are, then everybody starts to win, right? The care is more affordable. They can receive the care that they need, and higher quality care results overall. Hope that makes sense. Next question, Chuck.
Yeah, sure. So one of the questions that came in was a bit about the capacities, you know, and it's actually related to the prior question. When we were at the Becker's conference a couple weeks ago, there was some great conversation about how some health systems are starting to open their ORs up to maybe not 24/7, but they're starting to do a lot more procedures on the weekends and whatnot, because as the patients themselves are responsible for the payment of them, you know, you get a lot more seasonality towards the end of the year. They're going to want more hip replacements, knee replacements, especially on around those high margin types of procedures. And the question that came in that's related to that is as far as capacities, especially when there are capital intensive assets that you're already paying for anyway, what are some best practices around how capacities can be leveraged in that light? Maybe just to mix it up a little bit, if Zan, if you wouldn't mind speaking to that one.
Yeah, no, that's a really good question, and I think that's something we are trying to take a more broader approach to what expenses, how they turn into cost. And so, you know, when you acquire like a piece of a capital equipment, you really just have to do activities. But again, those costs are either fixed or semi-fixed, so that if you don't use that piece of equipment, you still incur the cost. And the way activity-based costing has been deployed in healthcare to a large extent, it looks like not using like a high modality imaging system. If you don't use it, you're not incurring costs, and you know, everybody can realize that a lot of those costs are fixed. It's either a lease of that piece of equipment or the depreciation. That the maintenance still has to happen. And the same is with even labor. You know, once the staff is scheduled and that schedule is committed to, that labor becomes fixed at that point. And so those expenses, you need to understand what is the capacity of that labor. And what we find is the ERP is the real source of that. When people make those justifications to buy capital equipment, or when someone's sitting down, a nurse manager, to make her schedule for her unit, she understands what her load is. She understands what load she expects, and that's how she develops and puts together her skill mix for the shift. So that's where that knowledge is about what that capacity is. But you know, the other piece of capacity that we can leverage is predicting cost in the future. So if we have a patient come in, as Mark indicated, a lot of times you can't predict the cost because you don't know what the volume is, and your costs are so tied to volume in traditional cost models in healthcare. But if you base it on capacity, you can predict what that cost is going to be in the future. And we can look at unutilized capacity, and while you still have an opportunity, you can kind of generate some more demand for it. But that becomes very important when you start to predict the cost of a care bundle. You know that they're going to be in rehab a month from now for 3 weeks. What is that going to cost? And if it's based on how many other patients are in rehab, it's very hard to predict that, not knowing who will also be there. But if you predict it on your capacity to handle rehab patients, then you can predict those costs. So it's a very important concept.
And you're right. I mean, there's a lot of high cost areas, you know, be they machines, be they, you know, rooms, be they buildings, that you know, unlike other industries, healthcare doesn't have a great handle in terms of how those are actually being utilized. You know, what percent utilization they have, how the utilization of that unit of capacity, or that you know, capacity constraint is actually then specifically aligned to somebody's procedure. It's still quite opaque, right? And if you start to look at, you know, what other industries do, they look at those, you know, high cost capacity constraints and figure out ways to optimize the heck out of them, right? Those are the things you want to be using all the time, right? Having high unutilized capacity is, you know, sort of something that is a problem that other industries work very, very hard to solve. And I think the reason why we haven't done it yet here in healthcare is because we haven't had the ability to really go after that kind of refined notion of how these costs actually allocate. But once we do, right, it really opens up the opportunity to be able to better and think about how we allocate those costs, how we leverage those, and will probably result in, you know, some more novel ways in terms of thinking about how one actually utilizes that capacity.
Awesome. There was a question to effectively go a little bit deeper. I think, Zan, would be a good one for you on the bundled payment concept. You know, especially how do we bring in post-acute care spending, and how do we tie all that together at the same time?
Yeah, that's another great question. And one of the big challenges we have right now with you know, in costing is, you know, our revenue is not tied to charge base. It's not this fee for service. So we may have a lot of charges hitting our CDM, but we're getting this one bundled payment that's going to cover from, you know, the pre-op testing all the way through maybe 90 days of rehab after the surgery. So how do we capture those costs, right? And how do we find what's really using our resources in that process? And if we just look at charges, it hides some really important high dollar costs that, again, we would have to allocate around very arbitrarily. So it'd be hard to know that this bundle for a hip replacement isn't costing more than this bundle for a knee replacement. Things like we see in the JAMA article, I think recently they talked about over $50,000 of a hospitalist's time is spent just dealing with insurance companies per year. And that's a cost you're not going to see because there's no charge for admitting a patient or discharging a patient. There's typically no charge code that's associated with that. Or you look at, $50,000 again plus dollars to turn over a nurse. Again, how do you quantify those things, and what are those things, those levers you can pull to decrease nurse turnover or maybe make it more efficient to onboard a nurse? But to go back to the bundle, it's really looking at that bundle, laying out that treatment plan, laying out that process, sitting with your clinicians, your department leadership, your stakeholders, understanding the process, and then putting those dollars, calculating those dollars for each one of those activities, and then bundling them together. Again, we'd like to get to the point where we can predict that so that when you're about to order a treatment plan or a bundle of care, you could see what those costs are, you're predicting those costs to be expected to be. So, that's where we're to with the data we're generating.
Awesome. I had a few questions that came in along the same light, and maybe I'll direct this one to Mark. Effectively asking, okay, we're maybe if I were to be so bold as we're being pretty greedy on this call, we're talking a lot about costs and dollars and cents. How do we now steer this information that we've come up with, that we've allocated out? How do we steer this towards the clinicians so that they can better engage with the patient, so they can better have better conversations with the patient to educate the patient in particular as to the options that they have for care?
Yeah, it's a great question. I think today, right, two things, right? Clinicians, haven't been trained in any of this, right? Their whole focus, rightly, is how to provide the best clinical care, and they've not been given the tools either to help them in terms of providing that information to their patients, right? But again, if you bankrupt somebody over their healthcare costs, one could argue that you may have violated the notion of do no harm, right? So I've found clinicians to be actually quite receptive once they know, once they have the tools and once they have the information available to actually be able to start to leverage that. So helping people understand, what their options are, not just from, and how they can use those options to help them better manage their care, right? And what they can do to help, based upon that information to make care affordable for themselves is, something I found clinicians are somewhat eager to be able to do. We just need to provide them with the right tools to be able to do that kind of thing. And patients with their, high deductibles and, all of the challenges that they have, they're also eager for that kind of information. Patients often leave, clinicians, quite befuddled in terms of what path they're going down and how that's actually going to impact them from an economic perspective. And just that befuddlement alone can lead to, folks choosing not to make decisions for their care. So, bringing this kind of information, forward into the hands of physicians so that they can better guide patients is exactly, where we see this going in terms of being able to provide, more, high quality, more low cost care, which is the whole goal of, value-based care.
Awesome. Kind of to follow up on that, I think, Zan, this would be a good one for you. What kind of, what's the best means of successfully doing this engagement? Obviously, you need buy-in from the clinicians, from the physicians, from the providers to be able to do this. such that they're actually receptive to it and they actually think, wow, you know, cost does matter. I can personally reduce cost. Obviously, the top of mind is always patient health. But if I can actually drop some costs, then I can actually serve some additional patients, you know, and that really perfectly aligns to most of the mission statements of most of the health provider systems. Zan, any thoughts on, to continue down this path of how to really reel in the clinicians a bit more and get their buy-in in that way a bit better?
Yeah, I think, and Mark covered this a little bit in the presentation, actually covered it pretty well, was the getting their buy-in and their advocacy and even their help in selecting what are the activities that utilize resources. You know, when we take this finance-only perspective and we just look at charges, say, they know there's lots of things in their day that are consuming resources that are and maybe changing the intensity of the use of that resource that aren't related to charges. So if we go to them and they know their processes, they know how they use resources in their department or along their service line, and getting their buy-in for that, I think that's one good way to get their advocacy. And then the indirect costs. So say they central sterile. We may allocate central sterile based on some kind of MSDRG weighting because it's easy in finance. But if you go to the surgeons and understand that process and the surgical teams, you may understand that it's, you know, related more to the number of surgical packs that they open in the case. So maybe there's another thing we want to track to better align those costs so they can understand, here's why you're getting more indirect costs associated to your procedure than your colleagues. And then, you know, then they'll really be bought into that. But also getting their buy-in on what the capacity is, you know, so they understand how much work can be done, because, you know, just getting more volume through at the same cost, that may look great from a finance perspective on the surface, but, you know, we really need to generate the most quality care for the resources we've committed to. And if you take that perspective when you're looking at cost accounting and you go to them and say, you know, how much care could you generate, you know, effectively this quality care from this amount of resources, whether it's a capital item or a staff skill mix, then you get their buy-in that you're looking at it from their perspective. You're not just looking at trying to decrease dollars. And then again, I think that once you get their buy-in, their suggestions, they understand the process. It's very transparent. I think, you know, they become an advocate for you. They become part of your team. And this really is for them because they ultimately control a lot of the costs, the things that they order. A lot of times they have no idea what those items cost, maybe some supply items, but when they order a treatment plan, it's very opaque to them, as Mark has indicated, what that treatment plan costs to execute, you know, in the health system and the amount of expenses. And if you can give them some insight into that, I think you'll find that they are interested in helping you, you know, get the most quality care out of the resources that you commit to. So, you know, just a different perspective on why we're doing this.
Wonderful. Well, thank you, Mark, Chuck, and Zan, for such an excellent presentation. Before we conclude today's webinar, I just wanted to turn to you three one more time and see if you have any final thoughts you'd like to share.
I just firmly believe that the time has come in healthcare for these kinds of insights. These have rolled out in other industries, and not because they're any, you know, smarter than anybody in healthcare, but because, you know, other industries have gone through periods of the same kinds of revenue pressure that is now coming to healthcare. The good news is the models exist. And the good news is that we now have, you know, electronic record systems, both on the clinical side and the operational side, that we can start to leverage to apply those models in the very, very complex world of healthcare. So I think, you know, very much the time has come, and I think this is going to be one of the one of the key differentiators with organizations that are able to thrive in this environment, and those that are not.
Yeah, and if I could piggyback on that a little bit, I think obviously health systems have very recently been completing largely across the country updating their EMRs. Really, they've been focusing on the clinical side of the fence, and I think the back office is really the next big step everyone's going to. But what good is back office if it's not explicitly connected to front office, if it's not explicitly connected to your clinical systems and tying all that data in together via means like a costing solution? And I think their big result that I know at the event a couple of weeks ago, again, the excellent Becker's CEO CFO conference, that was starting to really make itself evident was the changing nature of how finance in general will work in the future, thanks to these the synergies, thanks to the combined holistic view of data. And that to me is the most exciting thing. We're on the precipice of immense change and rethinking how finance actually works within a healthcare organization. And I would say, and I recommend to all of my clients that I talk with, it's never too soon to start thinking about how this is going to impact your organization, what type of change management are you going to need to embrace.
Absolutely. Well, that brings us to the end of today's presentation. I'd like to thank Mark, Chuck, and Zan for their insights today, and to our audience for participating. Enjoy the rest of your day, and we look forward to having you join us for future webinars.